Right. Hi, good afternoon or good morning, everyone. Thanks for joining us. Thanks for waiting a few minutes here while we tested and did a little bit of troubleshooting with the technology. We appreciate your patience and really appreciate you joining us today for a very important conversation with our friends at HealthLinc Medical Legal Partnership that partners with Indiana Legal Services in the state of Indiana. We're joined here today. We've got a little bit of tech issues happening, so bear with us, but I'm going to continue on with some brief introductions. So we're talking today about the role of medical legal partnerships in harm reduction models. What we know about the opioid epidemic and substance use disorder is that we are facing that epidemic while also battling COVID-19 as a pandemic. So what we're doing today is really helping to focus some attention on that continued battle that we are all fighting in our communities, is just to help people access care from wherever they are using various levers in the community, such as civil legal services. Let's go to the next slide. All right, so I promise I'll introduce myself and our speakers in a second, but I want to ground us in a quote from a SAMHSA blog that came out earlier in the spring of this year. So in working towards the prevention of substance use disorders, it's important to appreciate those social determinants of health, policies, and actions that precipitate adverse outcomes. Here's where we are today. Let's go to the next slide. The National Center for Medical Legal Partnership is one of HRSA's National Training and Technical Assistance Partners, and we just want to acknowledge that they have sponsored today's webinar. A couple of housekeeping notes on the next slide. You will notice that we are utilizing GoToWebinar today, and we do have a chat feature. So please, 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 we encourage you all right from the very start so we can keep track of your questions or comments that are coming through, as well as addressing any tech needs that you may have along the way. Utilize that chat box to ensure that we're able to support you and get to your questions during the dedicated questions and answers. April Daniels on the National Center for Medical Legal Partnership team, as well as Danielle Rahajason, are also online, and so they will be monitoring the chat throughout the presentation today. We have three basic learning objectives. First, we're going to just briefly, I'll go over this part, talk about the role that primary care and health centers in particular played in addressing the substance use disorder epidemic, in particular the opioid epidemic, and having served as an entry point for behavioral health services. I'll briefly explain, and then you'll definitely learn in deeper dive and detail examples of how an MLP or medical legal partnership can play a role in addressing the substance use disorder. The deeper dive will be presented by HealthLinc in Indiana, along with their partners at Indiana Legal Services, about how their medical legal partnership provides that holistic harm reduction and recovery intervention approach for their community. So who's here today? I promised to introduce myself, right? I've been speaking for a few minutes here now. My name is Bethany Hamilton. I'm co-director of the National Center for Medical Legal Partnership. I'm going to go forward a couple of slides to let you know who our guest panelists are. We are joined by first CEO of HealthLinc, Beth Roble, as well as Kara Jones, the Program Evaluation Manager from HealthLinc. And then on the legal team, we're joined by Sarah Everett, Senior Staff Attorney at Indiana Legal Services. They're representing the HealthLinc Medical Legal Partnership, but I do want to note that Indiana Legal Services has several medical legal partnerships throughout the state of Indiana that are working on various aspects of addressing substance use disorder and opioid use disorder for patients throughout the state. So I would encourage everyone to take a look at what Indiana Legal Services is doing broadly throughout the state, but you'll hear about one example today. So how are health centers the entry point? First of all, let's talk about where we have been since 2017. On the next slide, you'll see that a reminder that in 2017, then Acting Secretary of HHS really declared our opioid crisis as a public health emergency. Fast forward, right, during the height of the COVID pandemic in 2020, what the research teams at KFF found is that health centers are still addressing what is now an increase in need, an increase in individuals who are utilizing opioids and substances to address various stressors that folks are encountering through the pandemic. So we now have an increase in opioid use disorder and 18% increase in overdoses specifically related to opioids since the start of the stay-at-home orders in March of 2020. And health centers are still dedicated and committed to serving those individuals who are in the community and really battling substance and opioid use disorder. So you can see based on the charts what this looks like when you divvy up or look at what types of opioids our patients of health centers are facing, prescription versus non-prescription or any opioid. All right, so why is it so important? Why are we focusing on health centers today? On the next slide, you'll see that primary care, NAC has done in the research team at NAC, thank you NAC, just want to feature this particular chart from their chart book again that shows that primary care, specifically health centers, really serve as an entry point, a key entry point for providing behavioral health care services. In fact, right, mental health services as of 2019 really, or between 2010 and 2019, showed 188% growth rate in health centers providing those services. And we've also seen that staffing in this area has also increased. Want to point your attention, everyone, since we are here at the National Center for Medical Legal Partnership talking about bringing legal services into the picture, want to point your attention to that category of services called enabling services. And you'll see in the chart book what percent of virtual visits in 2019 were enabling services. That's where for health centers, you'll find legal services fit, specifically for health centers. And I want to note, right, that many of you joining us today may also be from other types of healthcare organizations. For health centers with their 330 grants, they do have a dedicated set of services under Section 330 called enabling services, and legal services as of 2014 is included in the as an enabling service. So this is how health centers are able to, I think, more and more so focus on bringing and integrating legal services into their work. Why does this matter, right? For addressing what we're addressing today, harm reduction, opioid use disorder, substance use disorder. Let's look at what SAMHSA has said about the road to recovery. So on the next slide, many of you all may have seen this graphic before. It appears in our 2018 issue brief on how medical legal partnerships can address opioid use disorder and help people in recovery. You may have seen this chart. This is SAMHSA's dimensions of recovery chart. And you can see in this chart, right, that there are these 4 clear dimensions: health, home, purpose, and community. In that health bucket, right, often we think about the behavioral health, the medical services, the psychological, the mental health services provided by the clinical teams, right? But I do want to note that legal services, and I'll talk more about this in just a moment before we transition to the HealthLink team, legal services are an intervention to address the health harming social and legal needs of patients in various communities. Some of those needs may appear in the home and housing bucket, right? Imagine not having housing or stable housing or safe housing. That is a direct threat to one's health and an obvious stressor and can really be detrimental to one's road to and journey to recovery. So we are definitely highlighting today for you how legal services can be delivered as a part of the medical legal partnership approach to health centers, broader recovery services approach. Excuse me. All right, so how do you define MLP? We're talking about medical legal partnerships. Many of you have heard me define this and seen the pie charts we're going to feature in a second. Let's go to the definition slide. This is simply defined as an intervention where we're bringing legal and healthcare teams together to collaborate and address those social needs that contribute to the health disparities and may have a remedy in civil law. And we know that MLPs are growing and expanding and beginning to partner with even your public defender, so working with the criminal defense sector, also working with DV providers, right? So we know they are continuing to expand, and the definitions related to this intervention and innovation will continue to flourish, and we'll begin to highlight more and more of those. What does this work look like on the ground? This will look very familiar if you've been tuning into our webinars in the past. What this work looks like, how we're defining it around the country is basically in this pizza pie chart spectrum, where you have legal services, direct legal assistance to address the patient's needs. You can have trainings that MLPs engage in. You also have clinical level changes that MLPs will carry out together, and then continue up the spectrum. They also engage in policy change strategies. We have several examples, and we'll talk about a few of those perhaps through Q&A today. The work varies for how civil legal services intervenes. This is just from our iHelp charts, where we talk about the different strategies that legal services can take on to be able to address those common social determinants of health and social needs. And they range, of course, right? We define I, income and insurance. You all are familiar with this. Housing and utilities, education and employment, legal status, such as legal status for veterans, and personal and family stability issues. When MLPs are engaged as a strategy, we have seen the impact in the area of mental health. So studies have shown that patients or your clients out there are reporting less stress and they do experience improvements in their mental health as a result of medical legal partnership services being provided. As it pertains specifically to the opioid epidemic and recovery, we do know that legal issues can be the hardest for individuals. Let's go to the next slide. Legal issues can be the hardest for individuals to overcome, and this is directly linked to their road, to their path, to their journey to recovery. So when we bring medical legal partnership in as an intervention through the health center as your entry point, you can certainly demonstrate impact and promise for individuals suffering from substance use disorder. How do we look at this from the harm reduction approach? We know that many of you who registered today really wanted to know, like, how are we even defining harm reduction? On the next slide, before I transition to our speakers, so you can learn from what their work is getting done as an example, let's just start with this baseline foundational basic definition. We're defining this very broadly. We're not just looking at MAT services, those medication assisted treatment services. We're not just looking at the needle exchange programs. We are including those. However, we are defining this very broadly as any behavior or any strategy that helps reduce risk or harm to yourself or others. I deliberately selected this definition that came from the CDC and one of their workbooks, Steps to Care, that actually applies this to HIV, STD interventions. I did that on purpose because it is the broad definition that we want to ground ourselves in when you hear from the HealthLinc Medical Legal Partnership team about how legal services was an intervention. They'll have some case studies and examples to explain how legal services is a part of their holistic harm reduction strategy at the health center. So we're going to transition to their slide deck in a moment to hear from the HealthLinc Medical Legal Partnership team. We have Sarah Everett, Beth Roble, and Kara Jones. As that slide deck is brought up, we're going to ask folks in the audience to please let us know what your questions are in advance. We have some of them already collected from your registrations, and we'll be sure to leave dedicated time to address questions and comments. Also, feel free to let us know where you're from and if you're carrying out any MLP work that is specific to addressing mental health, behavioral health, or substance use disorder. So we're going to pause, allow April to be able to bring the slides up. All right, thank you, and I'll hand it over to Beth first.
Hi, and thank you, Bethany, and your staff for letting us talk a little bit about what we're doing at HealthLink. I'm going to just talk briefly on how we got here and leave most of the stuff to both Sarah, our attorney, and Kara, who's been working on our MMRT program that really is about the opioid response to the opioid issue. So next slide, please. Okay, so this shows who is HealthLink, and that is actually Lake Michigan, and we are, I always like to say, we're on the North Shore of Indiana, okay, right by Chicago. We have the whole services that most health centers have. We've really been focusing the last 2 years, 3 years now on medication-assisted treatment. And then we're lucky enough to get our mobile integrated response team services grant for that. We operate in 5 counties, and we have 11 standalone clinics, 2 school-based telehealth clinics, and a mobile van. Next slide. So how did we get there, and why did we do this? And I want to, I know I've spoken before to some of you, but it really started in 2016 when East Chicago, Indiana, which is right in the center of 20% of the steelmaking capacity for the country, they found that they had a school and a public health that was built on or public housing on an old lead smelter. I'll never forget the day I got a call that said the mayor of East Chicago had said 1,300 people in the public housing needed to get out. I just happened to be at a NAC conference, and then I heard that HUD wanted us in East Chicago. We went down there, and I'll never forget, one of the councilwomen said to me, "You got to do something, Beth." And I go, we do a lot of HealthLinc, but I can't make the lead go away. And she shared with us an issue with an attorney that was going to meet all 1,300 of these people and say, "You're going to be rich because of this." And I said, "I don't know what to do." And I remembered some discussions with the Indiana Legal Services. So we actually made some connections, and they started to come to our clinic and start to work with those people. So they not only understood that this person was they weren't going to get money, but what were their rights for being moved out of that. So that's kind of, we started, and that started our journey with the Indiana Legal Services. And now I kind of fast forward, back one more, to, when the pandemic hit, we started to see that the, Indiana governor declared shelter in place. One of the examples, okay, so we thought, okay, COVID, things are going to calm down. They did not. We had a 55-year-old patient with disabilities who, the day that the governor said, do not, you can't leave, shelter in place, stay there, she got an eviction notice for 3 days down the line to vacate. And day one, they shut off her water. She was helpless, and we were able to get Sarah, I'll never forget that. She really thought it was going to be a quick little process. It was not. But I think what it did is it showed us that even during the pandemic, and maybe because of the pandemic, we needed to keep our medical legal partnership going, and we put it on steroids. Okay, next slide. So this kind of tells our history. I told you from one extreme to the other. We had the pilot. A lot of people wanted to know where our funding comes from. So we actually started the pilot in East Chicago with a local foundation. And then we were able to look at the Indiana University. There's a research arm funded an expansion and evaluation to some of the other clinics. We worked with a couple of foundations, United Way, Indiana Department of Health gets integrated behavioral health money, and we were able to use some of that funding from MLP. In 2020, we actually went back to United Way. We actually used our MAT funding that we got from HRSA, and then also our MERT grant that we got from the state. And you can see in 2021, we've actually added Medicaid managed care. So yes, have we had to piece it together from all different ways? But we were able to get it and really keep this the MLP going in that. Next slide. I think one of the things that I'm most excited about, and even though Sarah's been introduced from with the Indiana Legal Services, she's part of our treatment team. Our staff, has this resource, just like you would refer to a cardiologist or send them for labs. They send them to Sarah and through the MLP program right inside our EHR. And then the other cool thing is we've been able to use our MMP staff to educate the health center staff on what are the legal rights and civil rights of our patients and how that could impact their health outcomes. So that's been, so not only are we doing external with our patients, we're doing a lot of internal through Sarah training in there. Next slide. So I want to say this has not necessarily been a traditional approach to the civil legal assistance. We've kind of, as they said, there's a couple in Indiana, some of them just concentrate on this. We offer it to all our patients. And I think it's also the difference is that our attorneys and our legal staff, they've got to understand the patient's journey with healthcare and substance abuse. So it's a two-way. And also that there's a continuum. So maybe today we refer out to Sarah for one thing for one patient, but as she does this, something else will pop up. And that's okay, because we are on this journey together. Next slide. And you can see some of the people that we've worked with on this, the judges and everything. So I think this is the point I'm going to. The next slide, I think I might have even talked over one more. So, okay. So I'm going to sorry, Sarah, I'm going to turn it over to Sarah so she can do some talking. We all work well together.
Thank you, Beth. I appreciate it. I appreciate the opportunity to talk about the HealthLink MLP today. The MLP team consists of myself. I'm the only attorney on the team, and I have a full-time paralegal and an intake specialist. I also consider my team the entire HealthLink staff, and I consider my team the entire ILS staff. This is one reason I think partnering with a civil legal aid organization like ILS is a good model for MLPs. Indiana Legal Services and partnering with us allows the MLP attorney to share the best practices through a statewide organization. ILS has resources and information readily available that I'm able to share. They have projects that work with specialty populations. So for example, we have an immigration and language rights projects, the project that helps me a lot maneuver immigration issues. We have a military assistance program that is very beneficial when I'm representing a client who happens to be a veteran, and I can look at all of the resources that are available to that person. We have a LGBTQ project, which keeps me up to date on key legal issues. And we have attorneys who really stepped up during the pandemic to become leaders in unemployment and housing issues that help keep me up to date. So that case that Beth talked about, when that happened, basically on day one of pandemic issues, I was already familiar with the governor's orders and where we should be and the way people should be acting when the pandemic started. And that was all a result of my partners with ILS. So as a result of that, I feel like I'm able, as a small legal staff, I think we're able to provide the MLP with a diverse practice that addresses a wide variety of social determinants of health. For the most part, people with substance abuse disorders are unable to address civil legal problems due to a lack of affordable legal services, and access to justice is simply not affordable for many. In addition to affordability, though, people with substance abuse disorders face unique barriers that other people may not when it comes to accessing legal services. They may be reluctant due to the stigma they face from their legal community, from the legal community. There may be a lack of trust in general to authority figures, and they may see the legal system so powerful and punitive that they can't envision legal services helping them at all. So cultivating trust among people with substance use disorders and demonstrating models of success will help lead patients to access the services of the MLP. And that trust and relationship starts with the healthcare provider at the HealthLink clinics. They build that trust in the programs that are established by HealthLink, and then when we're added in as another realm of treatment, they have some trust in the legal assistance they're about to receive. So trust and hope is easier to achieve with a referral from a healthcare provider, and it allows us to address a variety of legal issues which further lead to positive health outcomes. We do that in a variety of ways. So I'll run down those kind of quickly. I don't want to eat up Kara's time, but I do presentations, whether I do those to direct audiences like the MMRT team or the community health care workers or the care team, or in general staff meetings at HealthLinc. We try to keep people up to date and show them how social determinants of health can be improved with a referral to the MLP. During COVID, especially, I used emails a lot to communicate with people, especially people at HealthLinc, especially the CHWs, the community health workers. We provide clinics in-house at the various HealthLinc clinics, such as housing, advanced directive clinics. You all might recall the public charge issues and immigration law that affected a lot of people a couple of years ago. And I hope we were helpful in providing information and advice regarding those matters. We're out there in the community with HealthLinc, at the various HealthLinc healthcare fairs and other HealthLinc events. Every time we're invited, we're happy to show up and be a part of that. And then HealthLinc has a newsletter that's meant for their employees. So it's another opportunity for me to share information as to how we can help patients. I've written articles with a wide range of topics, such as receiving stimulus payments, resources for military families, advanced care planning, immigration and COVID-19 vaccines. You know, there were many people that were worried about their undocumented status and whether that meant that they could not get a vaccine. Racial inequities, housing and health outcomes, regaining driving privileges, tips for referring patients to that MLP. And then, you know, what people like the most, I think, is anecdotal evidence and case outcomes. And we do that when we can as well, with also whether we have a release from our client or we keep the information so it's not identifying a particular client. So I want to talk about a little bit about the MLP and the harm reduction model. I think that was on the previous slide, but that's okay. The MLP allows a patient with a substance abuse disorder. Let's see. I think previous to that on your slides. Yes, that. The MLP allows the patients with a substance abuse disorder to meet with legal professionals who believe drug users have rights worthy of pursuing. And it improves self-worth and empowers them to begin taking their own health care seriously. So hope is important. And my hope is that patients can see they don't have to lose everything, that substance use disorders may be a detour, but it doesn't have to be a dead end to life. So I try to picture what it might be like if a loved one of mine had a substance use disorder, and what happens during the process of arrest and being incarcerated, and how an individual might feel. And at that point, you might think that that nothing else matters. But I think what we can do, even though sometimes people's criminal legal matters may overshadow their civil legal needs at that point, we can educate how there are ways to overcome those, whether that's expungement of the records or getting a driver's license back or various other things, whether it's custody of children, that would allow patients to understand that this isn't a dead end for them. When I say there, you know, for the MLP, we don't necessarily have a traditional approach to civil legal assistance when we're dealing with a harm reduction model. So what I mean by that is most of the time prior to working in an MLP, I'd like my client to be ready, whether that's in a custody case for children. I want the perfect client. I like to win. I like to win a lot. Most attorneys do. But I think what we need to do as a practice is redefine what win might be. So in a case without substance use issues, I might think that agreeing to a guardianship or agreeing to a modification of custody would be a loss, and I might want to press ahead for those things not to happen. But it might be a tactical choice to make an agreement for those things and to maybe fashion an order where you allow a time where there'll be a reassessment of someone's abilities to parent when they're ready to parent, and you can show that that is something positive that this individual has done for a child in that case. So in some ways, you have to look at this as not being just a traditional attorney with traditional clients and only taking people who are ready to attack their civil legal problems and win, but you have to meet the person where they're at. Our staff, we need to understand the patient's journey with healthcare and substance disorders. It's a continuum. These cases are never going to weave their way through the court system with the same trajectory as similar cases without substance use disorders at their core. We need to be prepared for relapse, non-communication with us, non-compliance with what we ask of them, and we need to stick with that person by their side. Having said that, drug use and overcoming substance use disorder is a continuum. And as attorneys, it's important that we advise the client what decision makers will expect of them. And there's no need to sugarcoat that. For example, in a child custody case, decision maker is going to want to see a person as a stable home and stable employment, and they stay out of criminal trouble. But we also need to show various ways we can assist in making those things happen. And we need to show our client and our HealthLink patient that there is a route to successful outcomes, such as expungements and driver's license being reinstated and children being reunited with parents and housing options being expanded for them. So again, just a detour, not a dead end in this. You can move to the next slide. So education on these. Judges are humans and they don't know everything. And I apologize to any judges that may be on the call. But as attorneys dealing with people with substance use disorders, we may need to educate them about our clients' recovery. And that may be where we use our healthcare partners as potential witnesses to explain the programs and explain the successes of the programs, where this person might be and what a judge might expect if, for example, they would allow custody or visitation or any number of other things that we might be asking a judge to do. Adverse parties. We can't really hide drug convictions in civil legal proceedings or other criminal matters. Everything's out there for the public to look at now, but we have to face them and we have to be ready to show treatment and the validity of the treatment. And then there's that perception in the community that we need to overcome. So as an MLP attorney dealing with these issues, you have to be aware of that. The public hears more about individuals who fail in a substance use disorder treatment. Here in LaPorte County, I live near LaPorte County. HealthLinc has a clinic in LaPorte County, and there's a recent death of a toddler who was reintegrated back into a home. I don't really know whether drug use was an issue in that case, but I do know the next case that we might be appearing before DCS might be pretty difficult in LaPorte County and in other counties when these cases are shared so much. So what we need to do, and the reason the positive cases aren't shared is many people who are successful in the programs, they don't want to share because of the stigma that's attached to their prior usage. And so we need to be prepared to show statistics and positive outcomes are possible, encourage the community to provide something more than punitive measures to help confront the national epidemic that we're facing, and really educate about our healthcare partners programs that are out there. So next slide. When I began working for the MLP, there was a question about, well, how do we stay relevant for COVID-19? I'm going to try to rush through this one, but I started in July of 2019, and because of the number of clinics and the geographic area that we were dealing with, I talked with Beth and I said, I think I can serve more clients and help more if I'm not sitting inside the clinics all the time, because the travel time was a lot and being there was a lot. So we already started working remotely a little bit from the clinics that we dealt with. Our team started paperless files pretty early on. And then in the latter part of 2019, I broke my arm, which forced me to learn to work from home a little bit and communicate with my staff and people in alternative ways. And so I felt like when COVID hit and we got the mandate that everybody stay at home, that for my MLP team, it didn't seem like a huge transition. I thought we stayed very relevant and very effective in what we were doing. We had to look at different ways of doing things. So remote signings, for example, I had a patient in a nursing home, a client in a nursing home, and there was no way I was getting inside that nursing home, not anytime soon anyway. There was always a COVID outbreak. And so one thing I did that I had never done before, I've had 32 years of experience in practice, but I've never done this. But what I did was ask for the nursing home staff help in signing documents that this person had to sign. And that was just the best way to get what the person needed to do. I worked with my HealthLinc counterparts, and we had a individual who was sight impaired. He could not read anything. So in Indiana, a lot of documents have to be witnessed by 2 people, and we had 2 HealthLinc staff stay with this individual while I read about 14 pages of documents and got those signed. But that was the teamwork that was necessary for us to do, and we were able to get all of that done. And remote notarization was another thing we had to become familiar with. The civil legal assistance needs changed and shifted for people. One example is unemployment benefits. Prior to COVID-19, I didn't know a single attorney who practiced with unemployment insurance cases, and I had never dealt with a case at all. Yet, thanks to our ILS teamwork and people who showed up as the leaders in that area, I was able to get one patient $10,000 in back pay and help others get thousands of dollars of unemployment benefits. So we had to open our minds to practicing not in the way, in 2019, we thought the year was going to go, but in the way that served our clients' needs, and stay up to date with changing laws and policies, governor's orders that came down. I don't know, at the first, I remember just at night, that's what I did. I read the governor's orders at night. So just a continual work with that. And I tried to pass along as much information as I could to our HealthLink counterparts, yet knowing they were on the front lines and they were dealing with probably ever-changing mandates as well. So I didn't want to be a pest. At the same time, I wanted to let them know that there were things out there that might be able to help their clients. I did a lot of that through our community health workers. So next slide. So areas of legal assistance that are helpful in harm reduction models. We've already talked about maintaining housing. Of course, if you don't have a safe and clean place to live, that's directly going to negatively impact your health. And we recently had somebody who thought their apartment was making her and her animals ill. I say thought that because I don't know. We never had to end up proving that, but we were able to get her relocated into different housing that certainly was better for her. Recently, we were able to secure a protective order and a provisional order and a divorce to allow a client to maintain housing without the threat of violence from her partner. We work in foreclosure avoidance, eviction. Of course, with eviction, always the idea is avoidance, but sometimes the win is just delaying the eviction for a little bit and allowing someone to secure all of their personal belongings. Maintaining relationships with family is important, and especially to individuals who are dealing with substance use disorder. I think some of the saddest cases I see are where people may feel they're going to lose their children. And if, my opinion is if we just take the kids away from people and that's the result, I don't know that that's too helpful for the children or the client in that situation. So we have a client now that we've been dealing with for over 2 years. She is maintaining a relationship with her child. It's she doesn't have full custody of her child. That's not the win in this case now, but she does still have a relationship with her child. A reintegration case I want to talk about is a case where we can offer expungements. Sometimes those are going to be down the line a little bit, but if we can tell people that that's a possibility, that's helpful. Same with driver's license. But sometimes our legal services we provide appear to be things that a person would not need an attorney to accomplish. But sometimes the layer of bureaucracy makes it difficult for a person to maneuver. So we had a client who was in prison for 20 years on a drug-related charge, and after he was released, he was losing his eyesight and no longer able to work. He needed Medicare and he needed Social Security benefits, and he couldn't get those because his original naturalization certificate was lost or stolen while he was serving time in prison. So I started with that, an advice letter, and just said, well, here's how you do it. But he came back with us because that wasn't, he wasn't going to be able to do this on his own. His birth certificate had problems because his surname was inverted. He couldn't get, if you don't have those, you can't get a license, you can't get identity information. He was at a loss. So we represented him through that process, and something that I thought, oh, I could send out a letter and tell him, hey, here's how you do it, ABC. It took our office 10 months to achieve, but we were able to do that for him. So those are some of the things. I'm seeing I'm running late, so I want to give Kara enough time to talk about what she wants to. So thank you for your time.
Hi. So my piece, we just wanted to talk about a couple of the specific applications and kind of how this looks in the clinics. So we want to leave enough time for questions. So I'll go through this a little quickly. I'm thinking hopefully that you guys will all get these slides. So always feel free to reach out if there's any clarity you would like from this information. But the first one is just to mention just a couple of these funding sources that Beth had mentioned. PIVIC is a large grant that we got in partnership with the Indiana Department of Health. The primary focus of that is increasing integration, and through that is how we staff our community health workers. You heard Sarah mention that a ton, and we actually were able to pull, ever since we have a team of about 10 community health workers now. A lot of what they do is working with patients on care management issues. So they screen for and address social determinants of health. They work one-on-one with specific target populations of patients to do even goal setting, to get them connected to other members of staff. Sometimes I've seen referrals to the community health workers that literally just say like to build trust, because a provider can't get a patient to go to any other appointments or specialty providers or things of that nature. So they're used in a pretty dynamic way, and we've done a lot to really increase their capacity and provide them with training and things. And so all of that to say, as you heard a lot of mention of them already, we do see over half of the total MLP referrals that we get are coming now from the community health workers, since they really started picking up steam in the clinics in 2020. And so again, a large part of that reason is just the nature of their position, and they also use Prepare, and they're the ones that are addressing that. Prepare is a social determinant screening tool. And we even have a little cheat sheet. And so there's a couple of questions where if they have a positive in 1, 2, 3, or 4 areas, the referral there is automatically like screened for MLP referral. One of them, do you feel safe at home? Are you afraid of your partner? There's a question about housing challenges. There's a question about if they've had recent criminal involvement, which wouldn't necessarily be MLP for this function, but they do a really great job of finding other local legal resources in the communities, even if they're not eligible for the actual MLP program. Next slide. The other large program that kind of conjuncts with this as well is our MMRT program. Mobile Integrated Response Teams. We've hired about 15 peer recovery coaches that work with response teams of law enforcement and EMS. We work with a ton of different community-based organizations throughout our counties to really try to work on these recovery-oriented systems of care and get anybody who has recently experienced an overdose or is struggling with substance use disorder, get connected with a peer coach and meeting them where they're at. And I love that Bethany connected back to those 4 dimensions of recovery. That health, home, community purpose is huge. And there's just a really natural fall into this MLP program. And I think on the next slide, we have an example of how you can see as we add these layers in our clinics. And again, Bethany, love that you referenced our health centers as entry points. And I think that's such a beautiful way to look at it. And as we add these services, we're making our entry points bigger, and we're adding them in more places. So as an example, we had a MMRT intake a while back where it was actually taking place at the clinic. And so our peer coach shows up with law enforcement and EMS. They usually have huddles before where they can kind of review their criminal history. They can talk about what the referral information was and kind of have a plan of action going in to meet with the person. This patient was a female. She shows up with her boyfriend. There seemed to be something going on. There was some domestic violence going on. The patient was scared of her boyfriend and needed some assistance in getting away. And this is a really great example where you can see these layers adding on that really continue to expand the whole reach and wrap around of service to get this person into help and to being in a better ground to really address their substance use disorder, because she's not going to be able to get into treatment and be productive in her recovery when she's living in a violent environment and she's scared. She doesn't have access to her medication. She doesn't have any other healthy supports or those types of things. And so the officer being there was able to intervene and get the boyfriend out of the way while the community health worker came in, got them connected, and donated some donated clothes from the community closet that we have at the clinic. The peer coach reached out, got them engaged with the local shelter. Our care team nurses and the provider on site got she had some chronic conditions, got the medications she needed for that, got her started on medication assisted treatment. All of that swimming around and connected to get this person really where they need. And so then if we can add again another layer with this MLP, again, you can see how that continues to expand this harm reduction of getting that person into a better position where in this type of situation, you could get a protective order, like Sarah mentioned, housing assistance if a divorce was needed, those types of things. So just really hitting home that point about how social needs really need to be addressed in tandem with the substance use treatment. Next slide. And then I think we just have a couple of quick slides here. We looked at a summary and saw that we had over 1,400 referrals since 2017 for MLP. We see that growing most years. 2021's not over yet, but then we also did see a decrease in in-clinic appointments, which I think is a lot of the screening access point to get those referrals in, which is why we see, I think, a little dip for this year. And you can see we only have about a 16% rejection rate. We do lose quite a few to incompletion, which is where we most often of the time lose contact with the person where they're not responding. And 42% of those total referrals had been accepted and completed, which means they saw resolution to legal need was. Next, please. And lastly, just wanted to provide just for any of the health clinics that might be interested of like, what does this look like? Because I know that anybody who works in healthcare is always very concerned with HIPAA. How does that work in sending this type of information out? And so we just treat that referral point as an ROI kind of intervention. So anytime that legal needs identified, the staff asks some required screening questions. There's a set of 3 or 4 questions that have to go along with every referral where you've confirmed that you've gotten an ROI signed. You're asking, when's the best time to contact them? Sarah even has them ask, is it safe to leave a voicemail? Because you don't know what that situation is. And the best time to contact them. And we get all that in the chart. It's within our electronic health record system. And then we have a staff person internally that acts as the coordinator for all of those referrals, who gets them internally. And then she liaises with Sarah's team at ILS to get them connected. And then they reach out to the patient directly, and it kind of goes off from there. So that's kind of the basic workflow of that piece. And so I will end there really quickly. So we have a little bit of time for questions. I think that's all.
Yes. Great presentation, great timing. I want to, before we miss the opportunity, we do have a couple of questions lined up and ready. But before I miss the opportunity, I want to sincerely thank Sarah, Beth, and Kara for taking time out of their busy schedule, serving clients and patients every day to present to our audience today. So I'm going to cue Danielle to unmute. We've had some questions lined up, and she'll be reading them out loud.
Yes, so Kara, I think this one is for you since you just spoke about it. Can you please specify, when you said rejected, percentage patient rejection, was that percentage patient rejection or legal services rejection?
So it would have been the percentage of the referrals that weren't accepted. So usually that rejection, Sarah can speak to this more, I would guess most often is just, it's not either from their income or from the type of case, like if it might have been a criminal case that they weren't able to help with. But Sarah could speak to that probably a little bit better.
Well, those two things, and then another thing that might come up for us is if it's a conflict, and we have those sometimes that, otherwise we could accept the case, but it's a conflict because at some point we've represented somebody else that might be involved as well.
Awesome, thank you. We have another question. I think it can go to any member of the panel. It's from a pediatric hospitalist in Portland, Oregon, and they are asking if they're interested in learning a little bit more about how folks are garnering institutional support for long-term monitoring of the effects of MLP intervention on mental health, especially given the extreme lack of resources and given the big demand at present.
Great question. Great question about how you all are monitoring for long-term outcomes and improvements.
I think, let me make a comment. We screen all our patients with a PHQ-9 for adults and CAD and KJ. And then our kids, they do the craft survey. And so we have my one wish list, many wish lists, but one of them is to get like a clinical researcher to start looking at this. We can do some data, and actually we've written a couple grants that we're hoping we hear from HRSA soon that will include some clinical researcher time. But that's where we are, yes. Kara's great at getting the data, but that I think that from the medical side, trying to see if anything is there is on our wish list.
Could I press Sarah for your comments as well on, you know, if in addition to looking at the health related outcomes for, you know, going after those grants, I'm wondering if you can add anything to the, you know, the legal outcomes, the social outcomes that impact the individual as well as the broader community.
Well, primarily my evidence would be anecdotal evidence. So, and that's just my lack of being a good scientist or researcher. But I can tell you, I've seen it personally. One of my very first cases was an individual whose husband, and they've been married a long time, but there was child molestation involved of their child. And when I first met this woman, you know, I didn't think a lot of her appearance, but when I met her the next time after she was divorced and we dealt with housing issues and other issues with her family, I almost didn't recognize her. And she told me at that time that blood pressure had gone down. She had lost weight, just so many different things and getting help from that. So mine would just be anecdotal. Probably there are people in our organization who are keeping better track of those things than I am.
Still very important, and I also think still also compelling in and across various settings across different audiences, depending on whom you're speaking to, whether it's a grant application or a policymaker, healthcare team and leadership looking to invest. I do note that, you know, we are talking about recovery for substance use disorder, and that is a lifelong chronic condition, right? And so any metrics really should align, any expectations should also align with that sort of long-term path to recovery for individuals and communities that are impacted. Danielle, any other questions?
Yeah, do providers ever worry about the time or the complexity of completing paperwork? And if so, how do you address that?
I don't think our providers are even filling out the paperwork. It's the community health worker or the nurse. I think they're pushing a button. Sometimes they, you know, through the EHR, Sarah, you might want to clarify. I don't think they're doing it.
Oh, I think a lot of those are just coming through the CHW or whoever's making that referral. And it's a pretty simple referral to make. There's just a very basic outline of what the legal issue is that the person needs with just contact information.
Mm-hmm. And I think that's kind of the nice thing about it being within our EHR system. So it isn't really, the only paperwork is just an ROI that they have to sign. So it's not very cumbersome on the clinic's end.
They're great question. Do we have time for, I think we have time for one more, Danielle. Do we have?
Yeah, it probably serve as a good segue to what's coming up in terms of training and technical assistance. But There's a question about getting a lot of resistance from the staff in moving forward with an MLP, and if there's any quick advice for that.
Beth, do you
Again,
want to
I
take this
didn't
one?
see anybody, we did the training. I think that was key. When we first started, we did a lot of training. And one of my cohorts down at Eskenazi, Dr. Hout, they have had one for a long time. And I remember before we started, I asked her, how do you know it's successful? And she goes, they're saying, I can't live without my MLP. And I think that's what we have started to see. So I know that isn't a scientific, but it's kind of like if I ever took away integrated behavioral health. We've had integrated behavioral health since 2005. If I really wanted to make some providers mad, I'd take them away. And so I think that I didn't see any resistance. In fact, once they're educated, it allows them, that was part of the problem. When we started the prepare, they're like, well, what are we going to do with all this? Now I know that, but if you give them something that starts with the provider will refer to, and someone's going to take care of it, they love it, because all of this has been going on affecting their patients' life and their health. And until we can resolve these issues, we can't, one of the first things we were trying to help a asthmatic lady who was living in the middle of mold. That is frustrating. Okay, I know I'm on my soapbox now, but but because we referred to the MLP, that person got into a clean, safe environment. Now we can start really working on our asthma. So I just think it's just think about everything else you add in an FQHC, where it's dental, behavioral health, whatever. These community health workers, and the MLP make their lives easier. Okay, off the soapbox.
I couldn't agree more. And I
Okay.
greatly appreciate every time Beth joins our webinars and gets on that soapbox. And I would encourage you all to, this webinar is recorded. I would encourage everyone to please tune in again. We'll definitely share the slides in one giant slide deck uploaded to the National Center for Medical Legal Partnership website. If it's okay with Beth, her email address is up on the screen. And the MLP team, I'm sure, would be happy to help you all figure out how to do something similar, implement a medical legal partnership that addresses harm reduction needs and models and approaches in your communities. We want to thank you all for joining, especially thanks to the HealthLink MLP team, Beth Robel, Kara Jones, and Sarah Everett, for sharing their knowledge, their experiences today, and we wish you all the best. Stay safe, everyone. Thanks. Take care. All right.